Good evening, everyone. I want to welcome you to our virtual prostate cancer event. Hello, I'm Bishop Tony Branch. I'm your host and the first vice president of the Brockton area branch of the NAACP. We want to thank you all for allowing us to do what? To enter into your social media feed this evening. This event could not happen without the unceasing and collaborative partnership between AdMeTech and the Brockton area branch NAACP under the leadership of our Phyllis Ellis. So we again thank you for this evening. But we're here for an important conversation. So why are we here tonight? Because prostate cancer does not affect everyone equally. Black men are 2.5 times more likely to die from prostate cancer than any others. This event will help you make informed choices. Talk about technology. Talk about what should be happening in your physician office. AdMeTech and the Brockton area branch of the NAACP are partners in encouraging all men to learn about prostate cancer, the risk, and to promote early detection. Why are we here tonight, folks? To save lives. So thank you for joining us. Dr. Stern, thank you for your leadership, and President Ellis, I know you're around here somewhere, so I take my personal moments because I appreciate both of you all. And specifically, I need to hug Steve Bernard for his unceasing leadership in this area as well, and others. Charge it to my mind, not to my heart, if I've missed your name. So thank you all. At this point, I'm going to introduce, and I have looked down at the screen, is Senator Mike Brady. Senator Mike Brady is a champion of the Massachusetts Prostate Cancer Program that made this and similar events across the Commonwealth possible. This program is focused on men at high risk of prostate cancer, including all men with family history and African American, Hispanic, and Latino individuals. The Honorable Senator Michael Brady. Please join us.
I think Senator Brady may be running a little bit
Oh,
late.
okay. 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 So you all, we have these. People are like working hard for the community, running behind a little bit, and that's okay. Because we have, and I really don't even need to, I could just say Phyllis, but I love her so much. So it's President Ellis. Ladies and gentlemen, why don't President Phyllis Ellis, president of the Brockton area branch of the NAACP, give us some remarks. You're on mute.
Phyllis, you're on mute.
Oh, that would do it. Good evening. Thank you, Tony. On behalf of the NAACP Brockton area branch, I want to express our deep appreciation for the long-standing partnership with Dr. Stern and AdMeTech Foundation. Since 2014, we have been proud to work together to promote prostate cancer awareness, and we could not have asked for a more dedicated and impactful partner. This collaboration has endured because of our shared commitment to education, advocacy, and the health of our community. When we began hosting prostate cancer awareness events in 2014, Brockton had the highest prostate cancer mortality rate among Black men. Today, that is no longer the case. And we believe the awareness and education provided through these events have played a significant role in that progress. Over the years, we have had the honor of hearing from leading experts, including Dr. Stern, who have provided vital information through detailed presentations, visual aids, and clear guidance on when and how to get tested. These events have empowered our community, and we know that education is key. We look forward to continuing this important partnership. Thank you, Dr. Stern, the AdMeTech team, our esteemed doctors and speakers, the health committee, and everyone who joined us today to support this critical cause. Back to you, Tony.
President Ellis, we thank you for that wonderful introduction and wonderful opening. And as I look down, now I'm looking down at the monitor, I want to say hello to our health committee, hello to Janet, and hello to Leona. I mean, Janet made sure that this remained on everyone's calendar. For every meeting that I can think of, Janet, we just hug you and love you. And Leona, I see your messages. Bishop, are you all set? Yes, I'm all set. So I'm really, really, really glad to be here this evening. But listen, these events are meaningless without clinicians that are competent, that have the academic background to really, really home into what's happening with prostate cancer. We love Dr. Stern, but one of the things that I also love in hosting these events is that the physicians, that the oncologists, the urologists, excuse me, that come in to give us information are the cream of the crop across the country. So we are in good stead tonight. So a part of me, why I look down here at the resume, my role is to introduce right now a Dr. David Einstein, assistant professor at Harvard Medical School and an attending physician. And if I say this wrong, again, charge it to my mind, not to my heart. It says here, janitory urinary medical oncology program at the Beth Israel Deaconess Medical Center. Dr. Einstein, if I've said that wrong, please straighten me out. But that's a pretty big word, and I can't wait for you to tell us what that means in terms of us being lay folks on this particular event. Dr. Einstein, welcome you to our virtual program.
I appreciate it very much. Thanks so much for having me. Great honor. And when I meet people at cocktail parties and they ask what I do, I tell them basically I specialize in any cancer that touches urine or semen. So that's kind of the more graphic describing that. But yeah, genitourinary oncology is basically that region of the body that prostate cancer belongs to, right? And so I see patients with prostate cancer, bladder cancer, testicular cancer, and kidney cancer. But tonight, of course, the focus is really on prostate cancer, which, as you say, is a huge, huge issue across America, but especially in the Black community. And so that's exactly why we want to address it. I'm just going to share my screen here and pull up some slides that hopefully you'll be able to see in just a second. And so I direct the medical oncology program here at BI in Boston. And we actually work very closely with the group at Signature in Brockton, although we are a separate group. And so I see a lot of patients who are referred up, and I'm always happy to interact with folks. I actually spent a good month or so working down at the Brockton ICU back in residency. So in any case, tonight we're going to talk a little bit about the top myths about prostate cancer. And this to me is really important because I have a lot of patients come to me with a lot of preconceived notions or misconceptions, which are not born out of any kind of ill will or it's not that they were looking to find bad information. It's just sometimes that information's out there. So I like to try to get out ahead of that. So these are going to be our top 10. I'm going to go through each one of these individually, and then we're going to have some time for questions at the end. Okay, so first and foremost, prostate cancer is common, but it's overdiagnosed. Maybe we just need to stop looking for it in men. It's not going to cause problems. It's something that people die with and not of. Well, it turns out the two things can be true simultaneously. It is the case that prostate cancer is very, very common. It's about 30% of the cancer diagnoses in men in the US. And the lifetime incidence, we estimate somewhere between 1 in 8, perhaps 1 in 6 Black men will be diagnosed in their lifetime. So, chances are everyone here knows somebody. And it's only a very small percentage of those patients who will unfortunately die of their disease. But a small percentage of a large number of people is still a large number of people, right? And so it turns out that it is still the number 2 cancer killer among US men. And so it's still something that we want to recognize, and we want to make this number as small as possible. So a lot of the people who are diagnosed are successfully treated. And that's a really important message, is that looking for it, you're looking for it because you can do something about it. Okay, myth number 2. So there is a conception that maybe everyone should get screened for prostate cancer. And it turns out that it's probably a little bit more nuanced than that. And I think in general, the take-home message should be, when in doubt, ask your doctor. And there are many people for whom we want to increase the amount of prostate cancer screening. But if we look at sort of governmental guidelines, it turns out that if we start looking at men who are over 70 or so, probably there's less benefit of looking aggressively for prostate cancer that isn't causing symptoms. Now, importantly, if you have symptoms, this does not apply. Screening is only in patients who don't have symptoms. So there's a whole debate now about whether President Biden should or should not have gotten PSA tests. We don't have the information, but ultimately, if he had symptoms, then this is irrelevant. Screening only applies to asymptomatic people. And so what do we mean by screening? Well, basically, that's predominantly checking this blood test called PSA, which we're going to come back to. And importantly, there are people out there who have increased risk of prostate cancer, among whom are Black or African American men. And certainly, if you have family history, that could also be very important. And so it's wrong to sort of take blanket recommendations like this and say this applies to everybody out there. We really need to customize this to individuals and subsets. Okay, so number 3, if I get tested for prostate cancer, I'll just have to get a biopsy and surgery and radiation, and all these terrible things are going to happen. So why even bother going down that pathway? Well, there's a couple of problems with this statement. So one is the fact that we no longer biopsy and treat everybody. And so traditionally, if somebody had an elevated PSA in the blood, that's the prostate number, or if somebody did a rectal exam, which we actually don't do a lot of these days, it's not as helpful, then that would automatically lead to a biopsy, which could, but not always, lead to a prostate cancer diagnosis. Importantly, these days, we're actually increasingly using an MRI scan to triage who does and doesn't need a biopsy. So we try to do a better job of only diagnosing the patients who really need to be diagnosed and try not to make diagnoses in people who don't need to be diagnosed and people who are very low risk to have really aggressive prostate cancer. This is just what that looks like on the radiologist image. This is somebody's prostate, and they can actually kind of go through all these different images, even though they look blurry to us, to a radiologist, this means something. And they can actually go and by and say, up here in the 5 range, this is something that likely harbors a prostate cancer that we want to know about. Whereas somebody down here in the 1 green zone, that's probably a prostate we don't need to biopsy. And so the fundamental message here is that we try to make diagnoses in a very personalized and selective way. And then getting down into the idea of surgery or radiation, these are things that they can have side effects, and it's not to diminish that, but it's really not the types of treatments that you might have heard about from somebody who got treated 20 or 30 years ago. And so there are a small minority of patients who do end up with urinary leakage or erectile dysfunction. But most of the time, we're not seeing dramatic effects on people's quality of life. And in those few patients where we are seeing that, we actually have a lot of treatments that we can do to address these. So it's not the case that somebody's stuck with some of these symptoms forever and there's nothing to do about it. Okay, this just sort of goes to show that we don't treat all prostate cancer the same. We try to personalize this. And so we try to determine who's at low risk and may not even need to be treated at all. Maybe we keep a close eye on those prostate cancers and only treat them if and when they become a problem. Whereas there are other people who are at higher risk and really should go down this pathway to prevent bad outcomes. Okay, so let's come back to that idea of a blood test. So prostate-specific antigen, or PSA, is a blood test. Any doctor can check it. And it turns out it's very specific for the prostate, but not necessarily prostate cancer. So it's only one way to try to figure out who might or might not have cancer. And so it turns out that just because a prostate gets bigger with age, that can drive up PSA levels. That's called BPH. And sometimes if somebody has an infection called prostatitis, that can also drive up PSA. So these levels always have to be interpreted in the context of everything else that's going on with the help of the doctor. It's also the case that you can have a normal PSA and have cancer. So we got to do a better job than just using PSA. We have to take into account all sorts of other things in deciding who needs to be biopsied and who needs to be treated. So PSA is very, very helpful. It's not to diminish the importance of this test, but it's also not something that says 100% yes, I do, or no, I don't have cancer. Okay, number 5. So some folks hear the word cancer and assume that that means a death sentence. And understandably, I just told you that it's the second cancer killer among US men. So it is a huge problem. I see these patients every day in clinic. And yet I'm seeing these patients oftentimes for a very, very long time. And that's because either we're curing them of localized disease, and I follow them for several years, and then I dismiss them back to their primary care doctors. Or even for men who show up with metastatic disease, I'm actually treating them for many, many years. And these are just graphics from some of our trials that tell us how to treat patients. And you can see, this is the number of months people are being followed, and the percentage of people that is still alive stays, unfortunately not at 100%, but not so far off. It's certainly not down here at 0. And so these patients are oftentimes living with their disease for many, many years, getting a whole sequence of therapies over the course of their lifetime. We're pulling out tools as we need them. I hear this one a lot. So, I don't feel anything, doc. How could I have cancer? I even heard this in the context of President Biden's diagnosis. How could he have bone metastases? Wouldn't somebody know about that? Was he hiding this? Well, it really turns out that the most common symptom I see is nothing. Okay. So just because you're living your life and feeling well does not mean you don't have prostate cancer. And the other thing is that a lot of men will have urinary issues, but there could be all sorts of other reasons why that might be the case as well. So some guys have big prostates in addition to having prostate cancer. It's much less common, but we do see this happen sometimes when somebody shows up in the hospital or in clinic with pain from a bone metastasis or weight loss from an uncontrolled, widely spread cancer, anemia or low blood counts from a cancer that's really impacting the bone marrow, or kidney failure from a cancer that's kind of blocking off the outflow of the kidneys. And these are the kinds of things we really, really want to avoid, right? These are patients who are showing up way too late, who really needed to be diagnosed at a much earlier stage where it might still have been highly treatable. And every so often a patient shows up with a cancer that's so bad that it's already, they've broken a bone because of it. If I eat right and exercise, I can prevent prostate cancer. Okay, so one thing that I try to emphasize to my patients is that prostate cancer is not someone's fault for not eating or doing the right things. It's mostly bad luck and aging. Okay, so I think that it's not to diminish the importance of nutrition and exercise. These are hugely important, but it's also not the case that prostate cancer is because somebody didn't do the right things. Okay, so what can diet and exercise help? Well, it's possible some of these things could help decrease the risk of developing an aggressive prostate cancer. And it may decrease the risk of something sort of transforming from less aggressive to more aggressive. But I think most importantly, it really helps patients get through treatment better. When somebody shows up with very well-controlled blood pressure and diabetes and things like that, it gives me a lot more room to treat the cancer as opposed to somebody who, is really in trouble from all these other issues. And I'll also say that some of the side effects of the hormonal therapies that I give, the number one prescription that I give is exercise. It actually helps people feel better. That sounds like a chicken and egg problem, right? If I feel fatigued, how can I do exercise? But it turns out if you do kind of a gradual stepwise program, people can come out feeling much, much better. And it definitely helps prevent cardiovascular disease. It turns out cardiovascular disease, heart disease, is still the number one killer, right? Even more so than cancer. And so most men with prostate cancer will not die of prostate cancer. They will die of cardiovascular disease. So we still got to address this. And this is also true for people who are getting hormonal therapies that might impact heart health. Okay, how about natural supplements? Will these do a better job at treating cancer and have fewer side effects than all the stuff that doctors do? Well, it turns out that some of these things have actually been studied. Not enough. We actually, we don't know a lot about natural supplements, and that's oftentimes the big problem is that we just don't have data. But here's a study that was actually done, a very rigorous study, lots of people participating and testing a couple of supplements and showing no benefit. And if anything, possibly slightly worse outcomes with some of these supplements in terms of prostate cancer risk. So we can't assume that just because somebody advertises something as quote unquote natural, that means it's either safe or effective. There's a lot of stuff I should say going out on about ivermectin at this point. I don't know who on the internet started that rumor, but leave the ivermectin for the parasites. All right, number 9, if I get prostate cancer treatment, I won't be able to work and I'll become a financial burden. So I totally get where men are coming from when they have concerns like this. Oftentimes part of the feeling of masculinity is that feeling of being able to provide for one's family and not being dependent on others. Now, I will say that most patients don't have to take significant time off work for treatment. There are some lifting restrictions after surgery, but those go away fairly quickly. For radiation, depends on the type of radiation that you're getting. It might be as short as 5 days, could be as long as 5 days a week for 5 weeks. But usually that means you're coming in very briefly, 15 minutes in and out. A lot of radiation centers even have like dedicated parking. And so many of my patients are doing that and going right off to the construction site afterwards. And the types of therapies that I do with hormonal therapy and my patients who are getting radiation, they can do everything they want to do. They're not radioactive. They can be around other people. They don't glow. So no worries there. Now, financial toxicity, that can be a problem, okay? And this is a fault of our medical system, the way we pay for drugs in this country. But the biggest issue that we run into is when we prescribe oral therapies for advanced prostate cancer patients. Now, we have ways of working on that. We really do not want to bankrupt anybody with treatment. And so we spend a lot of time looking for various assistance funds, and we have some excellent pharmacists who help with that endeavor. But this is something that we absolutely want to address and head off any way we can. And sometimes there's even assistance funds, excuse me, for things like housing, parking, loss of income, et cetera. Okay, last but not least, clinical trials, not right for me. So there's a number of misconceptions that happen in regards to research studies. And I'll list a couple of them here. So clinical trials are only for when everything else has failed, like at the end of the line. It turns out many of our clinical trials are actually much, much earlier, even in the setting of curative diseases. And so clinical trials might be trying to do a better job of curing. They might be trying to do a better job with less intensive treatment, or they might be trying things all the way along the line, okay? Clinical trials are an option at any time. Well, it turns out that if somebody's really, really sick in the hospital from their cancer, that's actually not a time that a clinical trial is open to them. So there are lots of caveats about when we can use these types of studies. A lot of people feel that clinical trials are going to test some experimental drug that's totally unproven. And by definition, any trial has to have some data that's makes it worthwhile to spend the significant time and money that are involved in doing a trial. But most of our trials are actually what we call phase 2 or phase 3 trials, meaning that they've already been tested in lots of patients, and now we're just trying to test to see whether they're more effective than another therapy. So a lot of times we already have a really good sense of these drugs. Sometimes they're even approved drugs for that disease. We're just using them in a different setting. Okay, a lot of people assume that a clinical trial is going to involve a sugar pill or a placebo, right? I might not know what I'm getting, or I might be getting something that doesn't treat my cancer at all. I can't think of the last time I've done a trial that involved a placebo. Very rare these days to, the only time this would be ethical is if there's truly no available therapy in a certain situation. So much more commonly, we're comparing against a standard therapy, or we're adding something to a standard therapy. By the same token, people sometimes assume that trials always involve being blinded or not knowing what you're getting. Again, this is pretty rare. Most of our trials don't involve this. Most of the time we know what people are getting. This would only be ethical if it truly was unclear which arm was better, and if it wasn't unsafe to do something like this. But I can't think of the last trial I was involved with that involved blinding. People sometimes think that trials are going to mean that I'm randomized. I'm told by a computer which group I'm going to be in. I have no choice in that. This is not always the case. Sometimes everybody gets the same treatment. Sometimes there is no comparison arm. It's everybody's receiving the same drug. So I think that we've covered a lot of ground tonight. I'm happy to open that up to questions at whatever point the organizers feel is appropriate. But these are the things that I've tried to hit on tonight, and hopefully this gives you a sense of where prostate cancer is going in 2025. With that, I'll thank you very, very much for the opportunity.
Dr. Einstein, that was an awesome presentation, and I'm wondering if I should. I mean, there are a couple of questions. Or Dr. Stern, would you like to go and have a conversation around the advances in screening, diagnosis, and treatment, or should I just ask a question?
Actually, I think Dr. Anthony did a great job of going
Yes.
over advances and current thinking, how to use these advances in patient care. I will focus on our prostate cancer equity resource program
Oh, okay.
that was created with the intention to bring these advances to Massachusetts men, particularly with the focus on Black, Hispanic, Latino individuals and other men at risk. Before I do that, I'd like to thank Brockton NAACP, Reverend Creighton, and everyone here for a very long-term partnership that resulted in dramatic shifts in mortality in prostate cancer among Black and white men in Plymouth County. Thank you so much. And Phyllis already addressed that. We no longer see Plymouth County at the top of any charts for Black or white prostate cancer mortality in Massachusetts. And one of the, in order to accomplish that, we had two major programs. One was public education and awareness. We have an event like that today. Second approach was developing prostate cancer equity program that I will describe in a minute that brings the best quality care available today to Massachusetts men, including men with the attention. Our priority focus was actually on Plymouth County. So, Emily, if you can please play my video, I'd appreciate that. My name is Reina Stern. I'm a founder and president of the AdMeTech Foundation, a nonprofit organization leading regional, national, and global programs in prostate cancer education, research, public awareness, advocacy, and clinical care equity. I'd like to express my gratitude to Brockton and ACP for a long-standing partnership over the last 10 years. The main goal of my presentation is to review our prostate cancer equity resource project, established to bring the cutting-edge advances in screening, diagnosis, and treatment to Massachusetts men and eliminate health disparities. Prostate Cancer Equity Project is an integral part of the AdMeTech's ongoing statewide program on prostate cancer that created a Massachusetts model of national leadership in public awareness, medical education, and research. The primary focus of our program is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. We would like to express our gratitude to the Brockton delegation to the Massachusetts State House who made this program possible. For public awareness and education, our messaging centered on the importance of screening and early detection, critical for saving lives. Early detection is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast with late diagnosis, when cancer is spread to other organs, only 28% of men remain alive during the same period of time. The centerpiece of AdMeTech's medical education is annual global summit on precision diagnosis and treatment of prostate cancer. Our summit has been recognized as a seminal event in shaping the state-of-the-art and future vision for patient care. Our summit brings together the key international experts representing every clinical expertise to review the best emerging clinical practices and research priorities. The latest 8th annual Global Summit took place in October 2024. This educational event showed rapid advances in patient care, including screening, diagnosis, and treatment. Since 2021, our summit highlighted that equal access to high-quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostic and therapeutic approaches, ensuring high-quality, personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, at this event in 2022, AdMeTech launched the Prostate Cancer Equity Resource Project in Massachusetts in collaboration with Mass General, Brigham, and UMass, with the mission to save lives and deliver high-quality care. More recently, experts at the Beth Israel Lehi Health System joined this effort. Supporting organizations include Latino Health Insurance Program and multiple NAACP branches located across the state. Any Massachusetts man age 40 and older can take part in this program. Our priority focus is on Black, Hispanic, and Latino men who are at higher risk of prostate cancer, delayed diagnosis, poor quality of care, and death. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today, and to support men every step of the prostate health journey. This program helps men to find an expert for the initial or a second opinion, in-person or virtual visits. We strongly believe that our prostate cancer equity resource, integrated with our large-scale public awareness campaign, has been placing Massachusetts in a strong position to become the first state in our country to eliminate health disparities. Experts of the Prostate Cancer Equity Program can address any questions about prostate health, from assessing an individual healthy man's personal risk of prostate cancer to informing men about all available options before and after screening, biopsy, and treatment. We are committed to supporting men every step of their prostate health journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined process of patient referral and care. This process assures that every man who comes to the program is taken care of in the way our AdMeTech team and participating doctors would like to take care of our families and friends. Emma Coyer serves as a manager of the Prostate Cancer Equity PCE resource. Emma is assisted by Erin Roberts, program coordinator, and Eric McClay, patient educator, and other members of the AdMeTech Foundation's team. When you come to us, Emma will work with you, our team, Mass General Brigham, UMass, Beth Israel, and other clinical partners to expedite medical visits and address any needs you may have. Together, we empower each man to make informed choices that are right for him before and after screening, biopsy, and treatment. If you have any questions about our program or need assistance, please contact Emma by phone 617-523-3535 or by email coordinator@admetechfoundation.org. I'd like to share with you a few recent examples of how PCE Resource Project has been making a difference. In December 2024, Martha's Vineyard, NAACP, asked us to help an older Black man who expressed a lot of confusion and concerns about his care. AdMeTech staff contacted Dr. David Einstein at Beth Israel who agreed to provide a second opinion. In February 2025, this man and his wife had a visit with Dr. Einstein, who provided a clinical consultation and contacted the original clinical care team to ensure a coordinated approach. Only last week, this patient and his wife described to me that as a direct result of Dr. Einstein's consultation, they understood their situation for the first time in the process of care and became clear about the next steps. The second example involves George Brickhouse, who in December 22 took part in the virtual meeting of the PCU resource organized by Steve Bernard of Brockton NAACP. During that meeting, George expressed the lack of trust in his care and difficulties in scheduling prostate MRI recommended by his doctor. I got concerned, and after the meeting, contacted Steve and asked him to explore with George if he would be interested in our PCU resource. In early 2023, George contacted me, and I suggested for him to consult with Dr. Kwok-Jin Trink of Mass General Brigham, who can ensure the best of class care, including high-quality MRI. George has been so happy with his care that he became an advocate for our PCU resource. In late 2024, Dr. Trink relocated to Pennsylvania due to academic promotion. As of last week, per George's request, we referred him to another leading clinical expert at Mass General Brigham to assure the continuity of his care. I would like to introduce George Brickhouse, who became so happy about the care, quality of care he received through Prostate Cancer Equity Resource, for him to actually provide his perspective on what it was like for him to receive care before he came to AdMeTech Foundation, Prostate Cancer Equity Resource, and after. George, please.
George.
Dr. Stern, first off, day of birth blessings to Bishop Tony Branch. Tony's going to have cake for all of us after this is over. He has guaranteed me that he will have a piece for everybody who has been on this call. So therefore, we will all share in Tony's birthday with him.
Amen.
I am so happy, but so blessed in the fact that love was shown to me first through Steve Bernard to say, hey, my brother, let me turn you on to something that I think you might have some interest in. And then through Dr. Stern, who we've had numerous conversations and one-on-ones in terms of what is going on. And I'm so blessed. And as I said, when somebody shows you love, you know that it's moving forward and it shows you that they care. In fact, I have an MRI appointment this upcoming Saturday, the 14th, which I'm excited about having to move forward with, because Dr. Stern, after Dr. Trend left, Dr. Stern put me in touch with Dr. Adam Feldman, who was her father's doctor. And so you can't deny love being shown and given to you and appreciated. With AdMeTech team, with the team and Dr. Stern and Steve, once again, just moving forward. What I want to see happen is that our community of people of color, and we all are of color because it all started in one place with Adam and Eve. So we won't go into the philosophical, religious backgrounds of everything that's going on. But the fact that I'd like to see our young people, our teens, incorporated in what they need to do to make sure that our races continue to prosper in good health and good leadership. And so that's something that Dr. Stern and I have talked about, and I put it forth that I just think that we can do more on an overall basis. The different agencies that represent our community can dig maybe a little bit deeper in how we can get our young people, our high schoolers, aware of, hey, how's your dad doing? How's your older brother doing? How's your uncle doing? If they bring it into the household, I think it just makes us stronger and to prepare for the future that is ahead of us, as we have those who would rather not see us be in that future. Hey, as I said, I got love for Steve, Bernard, and Dr. Stern, and for the opportunity just to participate with Bishop Branch's day of birth and my cake that's coming my way. Thank you all.
Thank you so much, George. Thank you so much. George, do you want to say a few words what it was like for you to be getting care before you came to AdMeTech?
Doc, it was kind of like, okay, your PSA shows this, then we need to do this. Excuse me, first off, what's the evaluation PSA really meaning to the layman who doesn't understand this? I've just been sent to you by my primary because you're part of the medical team, and he wants you to make your income as part of the team. And the fact that you want to jump right into, we need to do this and this and this, but you don't want to walk me through what this, and this is. And as I said, I was blessed enough to have Steve reach out to me and say, I'm involved with a Dr. Stern in an organization called AdMeTech. You want to sit in on a Zoom and just listen to what we do and how we do it. And after sitting in on that Zoom, and afterwards, my phone rings, and I've got Dr. Stern on the phone, said, George Brickhouse? And I'm like, yeah, do I know you? And she said, well, you were just on a Zoom with me and my team, and I'd like to talk to you about what we might be able to introduce you to. And she tied me into Dr. Trent. And before Dr. Trent left, Dr. Trent and I had talked about a program, bringing a program into Brockton to the high school. And Dr. Trent said, look, let me come out to Brockton so we can move forward on this. I will come there. We don't have to do this out of my office. We can do this right on site so I can see what you're trying to do. And just the fact that that feeling, that care, when people show that they care about you and people say that, hey, I love you. I'm not saying I love you, but I'm showing as best as I can my love to you. And the fact that people of color being helped by those who have grown through history as brothers and sisters with us. History has shown it at a bridge. History has shown it in Washington, and history speaks for itself. We united cannot be turned back because the story is already told and we already know what the ending is. We just have to go through it. And it's easier to go through it when somebody wraps their arm around you and says, hey, I care about you.
Thank you so much. Thank you so much, George. It's really appreciated. Not to mention that even through virtual long distance, I can feel your love here. I also want to say that what George described, that he felt that he was cared about, was exactly the reason we created Prostate Cancer Equity Resource. I will share something that I shared only once publicly a couple of years ago. When I came into this country, we were essentially destitute, my family. We came here from Soviet Union. We were not allowed to take any kind of money with us, any kind of possessions. And I also happened to be 7 months pregnant. So I received basic insurance. It is New York HIP HMO. I was lucky to actually get it as a pregnant woman. And I was referred by my physician to Brookdale Hospital, which was located in a black neighborhood in Brooklyn, New York, where we were. And so I did not know much about this hospital, but when the time came to deliver, I ended up in this hospital. And here I was. I had absolutely no English. I did not understand what I was told. I was absolutely terrified. I was the only white woman in that hospital, and my baby was the only white baby in that hospital. And every time I would talk to nurses and physicians, I would be left with the experience, and I was trying to speak English. And I was left with the experience that I was an obstacle on their way to be somewhere else and to do something else and to deal with somebody else. And the only saving grace for me were other women, Black women, who helped me, who were patient enough to hear my non-existent language, to figure out what's happening, and volunteer to serve as translators with medical personnel. And after that experience, I promised myself that I will back to the very community that showed me such grace, such incredible help at the time of my greatest need. And I'm always thinking about that Black community has this commitment to social justice. In Jewish community, we have a commitment to repair the world. And as recently was pointed out by Van Jones, who served in Barack Obama's administration, this partnership, this collaboration, this joint experience creates a double helix of hope. That's why we created Prostate Cancer Equity Program. At this point, I would like to turn it over back to Tony Branch in case there are any questions, and to Thomas, in case there are any questions from Tony or from someone at Facebook. Thank you so much for your attention.
Dr. Stern, thank you for your presentation. Brother Brickhouse, thank you as well. But my birthday was on Tuesday, but I appreciate the accolades. This has been not only a informative conversation, this really is a conversation, but it also just speaks about how much of a difference we can make with the right collaboration. Yes, with the NAACP and AdMeTech, both, Dr. Stern leadership and President Ellis, Steve Bernard, and members of the Health Committee, I see Reverend Houston's here. So the right collaboration works, and it actually saves lives. So listen, y'all know how I get. I'm not, that academic stuff. I have to ask the basic questions that were presented to me. And one of the first questions, I have some things down here with respect to community events, but one of the first things that I think that we probably need to really home into is that prostate cancer, how it relates to sexual dysfunction in men and its impact on relationships. Dr. Stern, can we just ask some difficult questions? Or can we just dive right into it? Some men don't want to hear this, don't want to hear what's going on with the prostate because they don't want to have an inability to perform. How are we addressing that in this day and age? Especially with all the commercials around Cialis and Viagra, but specifically, what is the capacity for someone that has had a diagnosis of prostate cancer, but to continue their intimate relationship? Is that a dangerous question? Is that inappropriate for the bishop to ask?
Not at all. Actually, if prostate, what we've started seeing, Tony, is that an incredible trend in switching to very precise diagnostics and very accurately identifying men who need life-saving treatment that can impact men's sex. And vis-a-vis just careful observation, as Dr. Einstein pointed out, active surveillance.
Right.
And so with cancer itself, unless it encroaches on nerves, or vessels, does not impact, particularly in early stages, does not impact men's sexuality in most men. Okay? But treatment does. And so we have far greater probability for a man to have just careful observation, active surveillance, as opposed to treatment. And active surveillance is not going to impact is not going to cause any complications, including difficulties having sex. After treatment, it is more complicated. And I actually would like to ask Dr. Einstein to comment. How do we deal with sexual dysfunction caused by prostate cancer treatment?
Thank you, Doctor.
Yeah, I am more than happy to chat about this. My living is spent talking to old guys and gals about their sex lives. I have zero problem talking about this in the clinic or anywhere else. And I thank you for bringing it up because I think there's a lot of stigma and embarrassment around it. I think first and foremost, it is important to note just that the cancer itself is not what's impacting sexual function typically. Now, prostate cancer is a disease of aging, and so is erectile dysfunction and loss of libido. Like those are things that can be normal parts of aging. But as Dr. Stern mentioned, it's really about sort of what therapies are we using and how are we using them. Now, we should probably go back to basics. What does the prostate even do?
Right.
I think a lot of people don't know the answer to that. But it turns out it's not involved in erections. It's not involved in orgasm. What it does is produce the semen, right? So it's producing the fluid that is helping sperm get nourished. Okay, so sperm are coming from the testicles. The prostate is making the semen, and it does not have a direct role in the sensation of orgasm or in achieving erection. Okay, so we kind of got to dissect out the anatomy a little bit. So what happens is basically if we remove somebody's prostate or radiate it, then they can still have the experience of an orgasm or erections, but they will not produce ejaculate. So in general, say what we would call a dry orgasm, okay, or near dry. And that surprises some guys. Sometimes they didn't realize exactly what their prostate did and what life would be like without it. So if somebody needs treatments, surgeries can sometimes impact nerve function, and that can impact the ability to have erections. For somebody for whom sexual function is a priority, sometimes that's enough to sway us towards radiation and away from surgery. But it really depends on the type of surgery. There's nerve sparing and non-nerve sparing. That depends on sort of how aggressive the cancer is. Radiation tends to have less of an effect on that, although it can accelerate the aging process a little bit. And hormonal therapy, what it does is actually it works very differently. And some types of hormonal therapy can kind of take away the libido by suppressing testosterone. And basically that lasts as long as the testosterone is low. And when the testosterone comes back, so too does the libido. So how we address it depends on whether the problem is sort of the spark in the brain or how the equipment's working. We got a lot of ways of working on the equipment. We can't really create the spark in somebody's brain. That really depends on testosterone. But we do spend a lot of time also doing relationship counseling and just saying, hey, there's a lot of focus sometimes on specific acts or, achieving certain things. It's not always about penetration or erections. Like there's a lot of ways of being intimate around that. And sometimes we try to take the focus a little bit off of that and actually ask men to really talk to their partners and say, hey, what's important to them? Because sometimes they're really worried about, pleasing their partner and leaving them satisfied. What the men think is important isn't always what's actually important to the partner. And so that's a really important conversation too. But I would say lastly that there are entire specialties devoted to helping guys achieve erections who want to achieve erections. And this goes well beyond pills, although pills are certainly part of the toolbox.
Right.
So we can talk about that in more detail if folks are interested.
Thank you, Dr. Einstein. And while we have you up at the mic, wanted just to take a step back on one of the comments that you had made. You had said that rectal, I guess the digital exam is not always helpful. So can you explain that just a little bit more? Because we understand that you need that rectal. You need whatever they do is unpleasant. Right, I can tell you that.
There's a lot of jokes about that and a lot of fear.
Yes.
And
yeah. Oh, go ahead.
I get it. So, the rectal exam has been something that doctors have been doing for a long, long time. And to some extent, it can help detect really advanced cancers. Like it has to be a pretty big tumor in order for us to be able to feel it. MRIs are much, much better. We can feel a lot more with an MRI than we can feel with our finger. And so increasingly, we've realized that just routinely doing digital rectal exams doesn't necessarily pick up a lot of extra cancers that we wouldn't have known about otherwise. In other words, in an asymptomatic person, typically that exam doesn't help us detect a cancer more than every other tool that I told you about. Now, if somebody comes in with symptoms, then they have symptoms and we work up the symptoms in other ways typically. On their way to getting that, there have been circumstances where I want to make a quick diagnosis and somebody who has what I think is widely metastatic prostate cancer, and I can do that easily with a digital exam. There are some circumstances where it might impact our treatment planning a little bit, but really the field is moving away from that, and it's not recommended as a routine screening approach anymore. So guys shouldn't be afraid of going to the doctor and asking about prostate cancer screening because they're worried that someone's going to stick a finger in their butt.
Exactly. Thank you, Dr. Einstein.
Sorry to put it bluntly.
No. We want to know. We want to know. It's the doctors are squeamish in terms of giving it to you, and so it's important to know. When I listened to you, I just wrote that note down. But let me just go on to this one. So all of us have, some of us are Fox News. I'm a CNN type of guy, but Fox News, CNN, MSBCN, or whatever they're called, they're like advertising this genetic testing, this agency that like life sciences that go from the crown of your head, or as we say in the church, crown of your head to your soles of your feet, to figure out what you're going to die from, or what are your genetic irregularities. What is your position on genetic testing for men that have had a history of prostate cancer in their families?
Yeah, it's a super important question. And as always, I'm always wary of anybody who's advertising on TV. Got to be real curious about what they're trying to sell you. So we absolutely see a big role for genetic testing in prostate cancer. And it's actually a whole separate talk in and of itself.
Okay.
In brief, for people who have been diagnosed with prostate cancer, there are some people who merit genetic testing no matter what their family history. So guys who have metastatic prostate cancer or what we would call high risk or regional prostate cancer, more aggressive prostate cancers, these are people for whom we're routinely recommending what we call germline testing, meaning doing a blood test or a cheek swab to look for genes that you inherited from your parents, that you share with your siblings and your kids, your biological ones, that is, that might put other people at risk for many cancers, not just prostate cancer. And that's a common misconception, is that, this is only going to affect the guys in my family and not the girls.
Right.
It actually turns out a lot of these genes, if they're present, can actually have implications for a lot of different cancers in men and women. So it's not the case that every patient with prostate cancer needs genetic testing for family genes, but we're doing a lot more than we used to. Now, if you don't have a diagnosis of prostate cancer yourself, then it's a different story. Usually we try to go to the people who are affected by a cancer before going to people who don't have a cancer.
Wow. Well, that's interesting. So we shouldn't be buying a membership to the life sciences place on CNN, huh? I don't know
Got
how
to be
much.
real careful. Yeah, I mean, the more you do sort of whole body testing for all sorts of things, the more junk you can start finding and not knowing what to do with. So we try to do things in a fairly targeted fashion for answering very, very specific questions. So I don't know exactly which company was advertising, but yeah, definitely got to be careful.
So,
Tony, you hear me?
Oh, I'm here. Yes. I'm doing all the. I'm sorry, I have a lot of questions, but go ahead.
I've got a question for Dr. Einstein, if you don't mind.
Yes.
Does sleep deprivation have anything to do with the enlargement of the prostate, or harm to the prostate due to sleep deprivation that comes as part of aging and part of, if you're dealing with prostate issues, then you're getting up 1, 2, maybe 3 times a night, and you're throwing off your sleep patterns. And the only reason I ask this, because I stumbled into something with my new phone, my Apple phone, and trying to learn it about prostate health and sleep deprivation.
Yeah, big issue. We talk about this a lot in clinic. It probably goes the other way around. So it's probably the case that people who have prostate issues tend to get up more at night to urinate, as you say, right? Or people who have been treated for prostate cancer sometimes have, lingering irritation to their bladder. So it isn't the case that sleep deprivation is causing prostate problems to worsen or causing them in the first place, but rather that the prostate problems are driving the sleep deprivation, which then, of course, has other downstream consequences.
Yes.
So we spend a lot of time trying to talk about how do you get through the night and what exactly is getting you up. Now, I see you chugging on that, Slurpee or whatever it is. That's one of the prime things.
Oops.
Oopsies. I'm a doctor. I see everything, right? So one of the big things we talk about is moving fluids earlier in the day and avoiding things like alcohol and caffeine, because those are all diuretics. There's a whole laundry list of other things that we talk about as far as medications, either medications that could hurt or medications that could help. Sometimes people are up at night because of hot flashes, from hormonal therapy. I have treatments for that. So I really spend a lot of time trying to dissect what exactly is the sleep disturbance. And sometimes people have background sleep disturbances, things that are unrelated to their prostate cancer. But again, this is happening in people who are aging. And so sometimes sleep studies for things like sleep apnea can be super helpful.
Wow.
I appreciate it, Doc.
Keep slurping.
Thank you. Thank you, George. Thank you for that question. And Dr. Stern or Dr. Einstein, I know we're wrapping up, but I have to ask this question, and because this is actually happening. So you're in your doctor's office. They express concerns. They've given you your PSA, and they automatically go to, you may need an invasive procedure. So you're sitting there and you're stunned by hearing my PSA is out of the, off the chart here. I don't know. What questions am I supposed to ask my doctor who's telling me I may need a biopsy? Are there like 3 that we can remember, like 3 strong questions that we can ask before we agree to have something evasive done to us? Or is that just an unreasonable question?
Absolutely, Tony. The first question to ask, the first and most important question to ask, are there any non-invasive diagnostic options are available to me before I will get an invasive biopsy? And
Wow.
this is a critical question to ask. There is a there is over the last 10 years, we've seen incredible growth and proliferation of non-invasive testing based on blood, based on
Mhm.
urine, based on imaging. We have incredibly important uh, uh, toolbox, as Dr. Einstein pointed out, in order to determine which specific man needs biopsy, which specific man does not need biopsy. And these decisions should not be made on PSA alone,
Mm.
because, as Dr. Einstein pointed out, PSA is specific to prostate.
Right.
It is not to prostate problems. It's not specific to cancer. It means that it can go up, as he pointed out, in infection, inflammation, benign diseases, not only in cancer. So right now we have very sophisticated toolbox that protects men from unnecessary invasive procedures. Do you want to comment, David, further?
Yeah, I mean, it definitely depends on the scenario. I think that sometimes there are non-invasive things that can help triage kind of who needs and who doesn't need a biopsy.
Mm.
Um, but ultimately, usually the proof is in the pudding, and we can't really tell somebody whether they do or don't have cancer without a tissue diagnosis, something that we can see under the microscope. Um, so I think that, asking the questions about like how likely is this to be cancer? How likely is this to be a clinically significant cancer?
Likely.
And that's what
Okay.
the MRI tries to get at. What are the chances? Um, and, is this the kind of thing that I might be able to get away with surveillance, which still involves biopsies, but is a lot less invasive than, say, a
Mm-hmm.
surgery? Um, I think these are all important questions, but definitely good ones to talk about with a primary care doctor, with a urologist. And if you have any concerns, that's what groups like these are for, right? And you can reach out and contact folks who will help walk you through it. We also have the Boston Prostate Cancer Support Group, bostonprostatecancer.org, with monthly virtual meetings and a whole meeting archive on the website.
And
So,
in case of any questions, please come to Prostate Cancer Equity Program. Please contact me or Emma Coyert at AdMeTech Foundation, and we'll help you get connected with experts like Dr. Einstein, who will sort it out. What is important to point out, if MRI alone, according to multi-center clinical trials of different sort of level of sophistication in MRI, MRI alone can decrease unnecessary biopsy by 40%. In great hands,
mm-hmm, mm-hmm.
I can reduce unnecessary biopsy by 80%. So it's a very drastic reduction in unnecessary biopsy. And unnecessary biopsies, they should not be done blindly.
So, but Dr. Stern, so can we just ask the dangerous question about health coverage? So, you all have spoken a few times about MRI, but we know that they are expensive. So, are they generally covered? I don't know if you know the answer to this by Mass Health Basic. I don't know.
Yes, to my
Oh, they
knowledge,
are. Okay,
MRI is covered. Obviously, physicians need to justify
the
the need
order.
for MRI, but MRI is a part of standard care these days, Tony.
I
As
appreciate
expensive
that.
as it is, uh,
Yeah,
MRI is not anywhere close to the cost of biopsy. Uh,
gotcha.
Typically, in procedures cost alone, but on top of it, biopsy can cause complication, fairly significant complication that require treatment. So if you look at the big picture, MRI cost, however expensive it is, does not come close to invasive procedures and the treatment of related complications.
Wow. Can I just ask one one other question? And I think, yeah, we're nearing the hour. So we've often talked about and I don't know if this has been, we haven't talked, I don't think we talked about it tonight, or at least that I can remember. I'm getting old here. But the age for prostate, the youngest age, Dr. Stern, Dr. Einstein, what is the youngest age that we should have our prostates checked through the blood work? What is the youngest age? Is it 40, 35?
According to the National Comprehensive Cancer Network, AdMeTech is aligned very strongly to National Comprehensive Cancer
Yep.
Network that has 28 to 30 leading cancer hospitals in this country. And they have a committee on early detection of prostate cancer that consists of world-leading experts. And according to their recommendation, which is cutting-edge recommendation setting up standards for the rest of the world,
Mm-hmm.
men with no risk of prostate cancer, average risk of prostate cancer, men who are not Black, men who do not have family history of prostate cancer, should start getting their first test, PSA test, at the age of 45. Men with high risk factors, such as family history or Black men, should consider starting conversation with their physician at the age of 40.
I was leading, as we say, us those that pretend like we're lawyers. That was actually a leading question. So I'm going to ask you this. So if you are tested because of the high risk, you're at 40, what are the chances, and I don't know if you can answer this, but what are the chances that you're going to have an issue with infertility?
Prostate cancer, to my knowledge, does not cause infertility.
Well, no, I think the question,
Treatment,
the
but
treatment, that's what I'm trying to get to. So I have a high risk, I'm diagnosed. My goodness, I'm about to get married 2 years from now. I'm engaged. We're still young. We're in our mid 40s. This treatment going to cause infertility? What should I be doing?
These days, what is recommended for younger men
Yes.
who are diagnosed with prostate cancer, and of course, at younger age, it's much less likely that men will have prostate cancer. Although when we are testing at younger age, we can determine fairly accurately the probability of each individual man developing aggressive prostate cancer over a long period of time, 10, 20, 30 years. But getting back to your question, okay, we have a young man who was diagnosed with prostate cancer. What do we tell him to do? And very frequently these days, young men are recommended to donate their semens
Oh, that's what
and
it
to
is.
keep their semen so that they will be able to have children through IVF, in vitro fertilization. Uh, David, do you want to comment on that?
Yeah, it's an issue I run into mainly with my testicular cancer patients, but certainly sperm banking is a very viable option. And there's actually ways of getting assistance for sometimes it's about $600 a year for freezing costs. So that would be most relevant for, a younger guy who's going to get some sort of definitive treatment for prostate cancer and will not make semen as he once did. Importantly, the testicles are still making sperm, so you can actually also withdraw sperm directly from the testicles if somebody didn't get sperm banking in advance. So that still is working just fine. And if somebody is simply getting active surveillance and getting biopsies periodically, that shouldn't affect their fertility.
Wow. Good information. Very good. If you two have just been awesome. But Dr. Stern, I'm going to tell you, I'm a little disappointed. Because you usually give us some great details on advanced technology, and now we're down to like 8 minutes. Is there anything new out there that you can tell us about that is less invasive? Anything out there?
Absolutely. There are incredible advances in novel diagnostics that can be obtained to look for specific prostate cancer markers in blood, in urine, We also have seen tremendous advances in imaging.
Oh,
And each test alone has great value. But if we combine, let's say, blood test or urinary test with imaging, then we can create a fairly precise prediction whether or not a specific individual man needs to have invasive interventions such as biopsy or treatment.
thank you so very much. Are there any more questions before we wrap up? All these smiley faces. This has been a this has been an awesome forum. Hey, listen, I know that we're down for the bishop to give closing remarks, but I'm looking at my president and I want her to say something before we leave tonight. Dr. Stern, again, you're awesome. Hugs to you and Dr. Einstein. President Ellis, can you give us some closing remarks, pretty please?
Sure. I mean, I was really impressed. Dr. Einstein, you're
Yes.
awesome. That was an awesome presentation. I mean, you broke it down in like simple language that we can all can understand. I
Yes.
really appreciate you coming on for us. And Dr. Faye, you're always
Oh,
awesome. And George Brickhouse, thank you so much. And Steve, I want to thank everybody, especially the health
we love
community,
Steve.
because they put so much into giving these um, events every few months. So thank you so much. And Tony, you know you're awesome, right?
No, no.
You keep it going. You keep it going. So thank you, Tony.
Your blessings to you all. You all, we want to listen. Thank you, Dr. Stern. Thank you, Dr. Einstein, and the members of our health committee, President Ellis, as well as I know we have Reverend Hudson Downey and others, and your staff, Dr. Stern, for staying over these late nights, making sure that these forums are actually, these presentations are actually being delivered across this great Commonwealth. Ladies and gentlemen, this has been AdMeTech and the Brockton area branch of the NAACP, bringing you our latest virtual event around prostate cancer. Because what is our goal? It is to save lives. Y'all have a good evening. Thank you. Take care.
Thank you.
So much.
Appreciate the opportunity.
Peace
Thank you.
out.